Good evening, everyone, and welcome to tonight's Men's Health webinar, September Prostate Cancer Awareness Month. And in recognition of that, we've got a men's health specialist, a urologist, great person, Dr. Eugene Park, who's going to present on the signs, symptoms, and treatment options for erectile dysfunction. Now, tonight, we want this to be an educational session. We want you to have the opportunity to ask your questions, have them answered. So we encourage you to submit those. Some of you have already done that beforehand, but if you want to do that now, tap on the screen of your mobile device or move your mouse if you're on a computer. A toolbar is going to pop up. Find the tool that says chat, click or tap on that, type your question in, hit submit, and we will address those questions at the conclusion of the presentation. Your participation tonight is anonymous, so don't worry about those questions as you ask them. No one else but the panelists here can see. And without further delay, I would like to introduce Dr. Eugene Park.
Hello, guys. Thank you for showing up. Really appreciate it. I'm going to be talking a little bit about erectile dysfunction. I know you probably have gotten little flyers and all that stuff about the subject tonight. I've got a series of slides here that I'm going to go over. Just kind of goes over ED in general. More specifically tonight, we'll be talking about the inflatable penile prosthetic. I'll get to that at the end, but we'll kind of give a little overview on erectile dysfunction in general here. So get this started here. There's a little screen here. You guys can use the QR code if you want a little bit more information on ED. This edcure.org, which is sponsored by Boston Scientific. You guys can scan that. Just hover over the code. You can get a link here. You have a couple seconds if anyone wants to do that. Boston Sci also has some products for incontinence or leakage. We're not going to go into that so much tonight, but if you're interested, again, here's another QR code for you guys to get some more information. All right, so this is all about me. I'm a urologist over at Urology Specialists in Sioux Falls. I'm located in Sioux Falls, South Dakota. I also go out to Brookings. I go to Hendricks. I go to Ortonville. I did my schooling at University of Illinois College of Medicine for medical school. I did my residency in Nebraska down in Omaha. It says I specialize in sexual dysfunction. I don't know if I would specialize in it, but I certainly have an interest in it, which is obviously why I'm here tonight. So learning about erectile dysfunction. So ED, what is it? How common is it? So ED is defined as the inability to achieve or maintain an erection firm enough to have sexual intercourse. It's probably more common than you guys think. It's 1 in 5 American men 20 years or older experience ED in their lifetime. More than half of men over 40 have some degree of erectile dysfunction. It affects approximately 39 million American men. So it's pretty common. People don't necessarily talk about it, but if you're suffering from it, you're not alone. The erection process, it's a pretty complex event, but it boils down to blood flow. So when arousal occurs, the body sends signals for blood to basically rush into the body of the penis. I don't know if you can see my mouse here, but these are called the cavernosal bodies right here, these two guys right here. And these are the areas that fill with blood, and that is what causes the erection. So as you get erect, the body compresses the veins so that the blood can't leave, which lets you maintain your erection. So another close-up of here. There's obviously a network of arteries and veins. These are nerves up here. So what are the causes of ED? Usually it's kind of multifactorial, but there are 3 main ones that we see. It can be a vascular issue or blood vessel issue. Diabetes is certainly up there. Medications can do it. Sometimes we see that after prostate cancer treatment, the nerves that control prostate or control sexual function are in the field while we do the surgery for prostate cancer. There's a couple slides here that'll show you why that happens exactly. Sometimes ED is actually a symptom or a precursor to diabetes, heart disease, and vascular disease. And we'll go over that in a couple slides here. Obviously, ED can have a broad negative impact on the health-related quality of life. So erectile dysfunction and diabetes. According to 2015 census data, 15.3 million men in the US have diabetes. People with diabetes tend to be less responsive to oral treatments. In men with diabetes, ED tends to be more severe and associated with a decreased quality of life. And in some patients, ED can be the presenting symptom of diabetes. The reasons why ED can emerge. 60 to 70 people with diabetes have nerve damage or neuropathy. You talk to people with diabetes, a lot of times they'll complain about numbness in the hands and feet. It's one of the reasons why we have to check their feet very carefully so they don't get ulcers there. And diabetes also accelerates damage to the inner lining of small arteries, which is why people with diabetes are at increased risk for things like heart disease. ED pills require the stimulation of or the nerves to be healthy and the blood vessels to be healthy. So these are damaged due to diabetes. Pills may not be as effective. It's just the same thing here. Factors that may increase ED in men with diabetes: advancing age, how long you've had your diabetes, poor glycemic control, or your sugars not being under control, vascular disease, diuretic treatment can make it worse, and heart disease can make it worse. So erectile dysfunction and heart disease. So heart disease may develop within 2 to 3 years of erectile dysfunction. This has been known for a while. ED is actually an independent risk factor for future heart-related events. The severity of ED is correlated with the extent of coronary artery disease. ED actually precedes coronary artery disease symptoms in almost 70% of cases. And I'll show you that here in a second. So if you think about it, anything that can affect arteries will affect all the arteries. And when you look at the size of the arteries, the reason you start seeing things in like erectile dysfunction before heart issues is because the blood vessels to the penile area are actually smaller than the blood vessels to the heart. So of course, these guys will actually get affected before the heart, which is why you may see erectile dysfunction before the occurrence of heart disease. So at 50% obstruction, the penile artery may cause symptoms of erectile dysfunction. So reducing your risk for ED, you can reduce your risk of erectile dysfunction by improving your heart health. So heart healthy lifestyles or include diet, exercise, physical activity, weight loss, quitting smoking. Smoking is a big one, reducing stress. Erectile dysfunction, low testosterone. Testosterone is one of these things that a lot of people ask about. So low testosterone, low T, occurs when a man's body produces less testosterone than normal. It's more common in men with obesity, diabetes, high blood pressure, high cholesterol, prostate disease, asthma, or COPD. How many men are estimated to have low T? It's about 4 in 10 men over the age of 45 have low T. For every 10 years increase in age, the risk of low T increases by 17%. A lot of different ways to treat low testosterone. That's probably for a different talk, but there are gels, patches, oral medications, injections, pellets, nasal gels. Just to go back, testosterone is not the only thing that controls sexual function. It's one of the components to it. So it is part of the workup for erectile dysfunction, but it's not the only factor that controls it. Erectile function and prostate cancer treatment. So when you see a urologist, we see a lot of these gentlemen because we're the ones who treat prostate cancer. We're the ones that do surgery for prostate cancer. The nerves and some of the blood vessels that supply blood to the penis for an erection lie very close to the prostate. It's actually kind of attached to the prostate here. These can be injured during the procedure. In order to get the prostate out, we have to cut the prostate away from this area. Prostate cancer treatments can affect the man's ability to achieve an erection on a temporary or permanent basis. So we have the option of doing something called a nerve sparing approach, where we try to spare these nerves as we're doing the procedure. But invariably, you have to cut into some of them. What we normally tell people is when you have a prostate cancer surgery, your function is going to be defined by your preoperative function. So you're never going to be better than before surgery, but if we can spare the nerves, the best case scenario is you're going to have the same function that you had before your surgery. Just a little bit of a closer picture of this area here. Sexual dysfunction after radical prostatectomy. It's pretty common. It kind of depends on who you're talking to and how people define sexual function, but it can affect 25 to 75% of men. Even with the nerve sparing approach in the robot, ED may persist a year or more after surgery. Radiation can also affect sexual dysfunction. When I consult patients, I normally tell them it's a slower process. Radiation changes sexual function changes after radiation are slower because radiation changes are slower than surgery. Erectile dysfunction is something called Peyronie's disease. I'll kind of gloss over this one a little bit, but Peyronie's disease is a disease of curvature. I recently saw a commercial. There's a medicine called Xiaflex that's right here. They're on TV. They're using a bent carrot to kind of show off their product. But the idea here is you get some scar tissue and it forces a curvature of the penis. It's kind of a scarring process. There are different ways to treat it. There's an injection called Xiaflex, which is an enzyme that can help dissolve what we call a plaque. You can have surgery to kind of straighten things out, or you would put a patch on top of there. The reason we talk about this today is that the implant that I'm going to talk about can actually help with Peyronie's disease as well. The implant is used to correct, it can correct sexual dysfunction and Peyronie's disease simultaneously. Other treatments for erectile dysfunction. I'll talk about this one here. There's a lot of people advertising something called extracorporeal shockwave therapy. If you know people with kidney stones, we use shockwave therapy to break up stones. Some people are using that to actually use those sound waves to what they consider stimulating the blood flow to the penis. The AUA, or the American Urologic Association, still considers this experimental or investigational. Same with stem cell therapy or platelet-rich plasma therapy. So if you see anyone advertising that or trying to present you this as an option, you should know that our official society considers those investigational. So what are your options for erectile dysfunction? If you guys are suffering with this, most of you probably know most of these options, but for those who don't, basically there are oral medications, there's injectable medications, there's something called a vacuum erection device or a pump. There are suppositories or pills that can go inside the urethra, the urine channel, to give you an erection. And there's something called a penile implant, and that's kind of the focus on tonight. So oral medications are PDE5 inhibitors. How do they work? How effective are they? Common side effects and some cautions. So these medicines basically increase the blood flow to the penis. How effective are they? They're effective in about 60 to 80% of cases. Efficacy can be affected by food. I usually tell people to take it on an empty stomach. Most common side effects: headaches, facial flushing, can cause muscle aches, upset stomach. You always hear about the erection lasting more than 4 hours, or something called a priapism. That's actually pretty rare as long as you follow the directions. You shouldn't take them if you're taking something called nitrates or nitroglycerin. It can drop your blood pressure. If you're on something called an alpha blocker for your prostate, if you take it too quickly with your alpha blocker, it can drop your blood pressure. So just talk to your doctor about that if you're using them. Intracavernous injection therapy, or just injection therapy. So injection therapy is probably one of the more effective options that we have. It's usually a combination of certain drugs that will cause the same effect as the medication, but you're injecting it directly into the penis and it has a direct local effect. So once you inject, you get an erection between 5 and 20 minutes. How effective is it? Approximately 40% of men discontinue. It's effective, but 40% of men will discontinue the therapy, typically within 6 months. Common side effects, penile pain. This medicine can give you the erection lasting more than 4 hours if you're not careful. It's a result that we call dose dependent. So you have to be careful with how much you give yourself. If you give yourself too much, you will get an erection that won't go away, and that can lead to scar tissue and permanent damage. Common reasons for discontinuation, failed erections, pain. Some people just don't like to inject the side of the penis, which understandable. Vacuum erection device. The vacuum erection device is a pump that basically will draw blood into the penis, give you an erection. What has to happen after you gain your erection is you place a ring at the base of the penis to maintain that blood flow. It's actually a very successful way to get an erection. Some people, are okay with it. Some people aren't. It can cause bruising, discomfort, penile numbness, and coldness. Most common reason for discontinuation: inability to achieve and maintain full erections, or pain and discomfort. The suppository, there's something called a Muse suppository that exists. It's similar to the injectable medication, but instead of injecting it, there's a pellet that goes inside the urethra, the urine channel. And what it does is that medicine kind of diffuses into the body of the penis, and it's supposed to give you an erection. Me personally, I don't prescribe this very often. I think a lot of guys find it uncomfortable to use, and the efficacy is not great. I'm not gonna lie, I don't see a lot of guys who get great results with this. That's one of the reasons why people quit it: insufficient erections, urethral pain and burning. They switch to another ED therapy, or some people get natural return of erections. The penile implant. So this is what we're really here to kind of go over. So the penile implant is an implantable device that goes inside the body of the penis and helps you get an erection. So what's being described here is a 3-piece implant. These are what we refer to as the cylinders that go inside the body of the penis. They'll fill with fluid that is stored in what's called the reservoir, and it's controlled by this pump. Squeezing the pump moves fluid from the reservoir into the cylinders here, and that is what gives you an erection. When you're done, there's a little release button. You push this, you force the fluid back down here and back into the reservoir. How effective is it? 98% of patients reported erections to be excellent or satisfactory. Most common side effects, complications: postoperative genital pain or infection, mechanical malfunction. We'll note here at 7 years, 94% are still fully working. So they do last. There are different types of implants. There's something called a malleable implant, which is just the cylinders. It doesn't have a pump. It's kind of a bendy cylinder that you manually put up and put down. There's something called a 2-piece penile implant that doesn't have the reservoir. The 3-piece, I think, is the one that most people recognize. I think most people kind of consider it the Cadillac of the prosthetics. let's see, oh yeah. So Boston Scientific's device is coated with something called inhibizone. It's actually adherent to the device. It's a way to try to prevent infections. Infections are the things that we worry about the most, really, with this type of procedure. Anytime you put a foreign body inside the body, it can get infected. And it's one of these things that we want to try to avoid. So we do things like we do a long scrub on the skin to try to kill bacteria. We try to speed through the process so that we don't take too long, expose the parts to any types of bacteria. That inhibizone kind of helps create a zone of inhibition around the tissues and around the implant itself. So we try to do everything we can to prevent infections from happening. So yeah, it's clinically proven to reduce the risk of infection. This probably is more related to the other stuff, but that's not exactly related to infections. But so yeah, the benefit of the prosthetic compared to injections and all the other options, this most closely mimics a natural erection. You're not injecting yourself. It's a little bit more spontaneous than waiting for the erection to occur after taking medications or using a pump. Provides rigidity when inflated. These things are actually pretty sturdy. They've got pretty good, what we call tensile strength. It has a natural flaccid appearance when deflated, so people don't need to be knowing that you have a device when you're not inflated. Let's skip here. So the procedure itself, it's an outpatient procedure. We do it under anesthesia. There are two ways to approach it. It's a small incision to the scrotum or above the pubic bone. I will actually do it from above, and the incision is right above the base of the penis. Through that small incision, we can do the whole procedure. Generally speaking, it takes a few days to return to your regular activity or light activity. Usually wait about I personally wait 6 weeks before allowing you to use the device. There are some people who will let you use it sooner, but I've been moving closer to the 6-week wait. Cost and coverage. This is where it gets a little more complicated. There's so many different insurance products out there. But in general, insurance, in general, it's incontinence, or not incontinence, sexual function treatment is covered by insurance. We work with you guys closely if you decide you want to go through with this. So we don't like to do this and stick with luck bill. So if you ever come to see us and get set up for something like this, we will work with you guys on making sure that everything's copacetic before we proceed. Here's some testimonials here. Unfortunately, I couldn't get any of my patients to come in today, but benefits of the penile implant: 97% patient satisfaction, 98% partner satisfaction with the 3-piece implant. It's clinically proven to reduce, or the inhibizone is clinically proven to reduce the risk of infection. Affordability, typically covered by insurance and or Medicare. Long lasting, 89% still in use after 10 years. I think this is what a lot of guys go for. It's that natural appearance in the erect and flaccid state. Obviously, if you feel it, you're going to tell that you have an implant, but it does have a fairly natural appearance because it's inside. Typically does not interfere with ejaculation or orgasm. It's spontaneous. You can have sex when the mood strikes. So risks of the procedure. So any surgical procedure is going to have possible adverse effects. We talked a little bit about the risk of infection. This is a mechanical device, so there can be parts that fail. The pump can fail. The reservoir can do things like rupture, or there's something called auto-inflation that exists where the device kind of inflates itself without you trying. Typically, those will require surgery to kind of go in and revise the device. You can have pain. It is a sensitive area, especially when we do the procedure. It's usually around the healing process. People with diabetes, spinal cord injuries, open sores may have an increased risk of infection. Generally speaking, we say that the national average for prosthetics is about 2%. So it means 98% of the time things are fine, but there is a 2% chance of getting infection with one of these devices. So as a summary, ED is a common problem, maybe associated with other conditions. There's a lot of different options available, and the implant could offer a long-lasting and satisfactory solution. So I'm going to take this down here. I think there were some questions. And
so we'll start with some of the pre-submitted ones.
Sure.
The first question here, patient is exploring options, looks like has looked online and seen some over-the-counter medications.
Sure.
And they're wondering about efficacy, everything from truck stop pills, things you see there, to different treatment options that you can find online that claim they're 100% effective. Do you have any?
So this is what I tell everyone when it comes to the supplement. There's no shortage of supplements out there. And I'm not here to say that supplements can't work. The thing about supplements is that they're not regulated, and that's my biggest issue with supplements. It's not like drugs that are controlled by the FDA, which have to be rigorously tested. So you don't really know what you're getting when you're taking a supplement. And the other part of the thing with supplements is that there's no governing body that regulates what they claim. So if you actually look at a lot of these bottles, they'll tell you, hey, this has a 3,000% effect compared to blah. No one has to check that. They're not going to get fined for making a statement like that. Drugs that are controlled through the FDA can't make claims like that if they're not true. So you don't know what you're getting. There's actually a lot of people out there who do research on supplements, and part of the problem is what they're saying is in the ingredients is sometimes not even what's in the product. And so there's a safety issue. So for me, my biggest concern is there's a lot of, especially what we call hepatotoxic medicines out there, or products out there, or liver toxic products. There's a lot of people who get into trouble and go into liver failure because they're taking these types of medicines. So my personal advice is I would stay away from supplements more from a safety profile. The other thing I would say is this: if it really was that easy to have an ED cure that you could just set out to the market like that, they wouldn't be selling it out at truck stops and things like that. I mean, they'd be selling it for a much bigger profit. And so, yeah, I'm sure some of them work, but I don't know if it's worth the safety risk.
Thank you for that response. The next question isn't related to trauma. It sounds like this person was in some sort of accident, and looks like 7 months ago, and after the accident, lost the ability to achieve an erection. They wanted to know if they'll be able to get their erections back on their own, and if not, if there's anything that can be done.
Sure. Without knowing more details, it's hard to give you an exact answer, but yes, any kind of trauma, especially if it requires a big, like, abdominal surgery, or if you had to have work on your colon, for instance, or the colon had to be resected, things could have been affected from that. And like I said, I can't go into details because I don't know the mechanism of injury or where the injury was. If it was just a matter of things like stretching of the nerves and things are irritated, yes, things can come back. Nerve damage can take a while to return. So it's one of these things that it's probably reasonable to give it a little bit of time to see if things come back. If they don't, depending on the mechanism of injury, any of those options could still work for you. It's just a matter of knowing what exactly happened, and it may be that maybe we can treat you with pills, or maybe you can use the injections. But even if that's the case, if none of them work, we could always talk about moving towards something like a prosthetic.
Thank you. So a bump from the pre-submitted, we've got more of those, but in seminar question, would everyone be a candidate for the implant? That's the question.
No, not everybody. In general, what I do is if you come to see me, I want to make sure that you don't have like severe heart history or severe lung issues. I do what's called a clearance. I want to make sure your primary doctor thinks that you're healthy enough to have an anesthesia. There are some people who are on things like blood thinners, and if you have something like a really strong history of strokes or heart attacks, sometimes your doctors won't agree to let you be off blood thinners to do with surgery. Typically, we get you off blood thinners so you're not bleeding actively during the procedure, and then we get you back on after the procedure. But yes, there are situations where not everybody is a candidate for an implant.
There's related questions where age being a factor, and a pre-submitted question, but somebody in their 70s, are there treatment options available for somebody?
Yeah. I think all the options are available. I mean, as long as you don't have a contraindication, if you're taking nitroglycerin, for instance, I wouldn't prescribe you Viagra or something like that, because that's an absolute contraindication. But my general rule of thumb, or the general rule of thumb in surgery in general, or in just speaking generally, is that age is not really a factor that precludes people from surgery. It's more of a, what is your medical history? I mean, there are some guys who walk in who are 70 who look like they're 50, vice versa. Sometimes people are so sick, they come in at 50, they look like they're 70. So yeah, just because you can still have treatment, age is not something that will stop you from getting treated. It's more, what are your other medical issues?
Thank you. Now, there's a question about a couple questions. Are there qualifications that need to be met for Medicare to cover the procedure?
Yeah, we go through this laundry list of questions. Generally speaking, most insurances want to know if you've tried a couple other options. There's a laundry list of questions I have to ask. They want to know if you have any substance abuse issues. They want to know if you're diabetic. If you have any psychiatric diagnoses like anxiety, depression. It's fine to have those. They just want to know that you're treated for those. In people who've had prostate surgery, you don't need to have a screen for any kind of hormonal tests, but in people who haven't had trauma or prostate surgery, we have to run some hormone tests to make sure your hormones are okay.
Thank you. Now, a question about the surgery, and how long does it take generally?
It depends on who's doing it. I did some training last year out in Florida. There's a Dr. Perito out in Miami. He's done thousands. I mean, he does something like 800 a year. He can do them in like 20 minutes. I can't do that. I don't do thousands, but I'd say in general, it's about an hour or so, the procedure itself.
Thank you. Now, if there's a question, a gentleman who had prostate cancer treated, and this is many years ago, it sounds like, and has been experiencing erectile dysfunction for a long time without successful treatment. If years have passed, are there still things people can do to get their erectile function back?
Yeah, this time doesn't really make a difference. I'd have to kind of know. So if you're talking about, will I get spontaneous function back? If you haven't gotten it back in a year, chances are it's not, your chances of getting spontaneous erections is not great. That being said, again, you really shouldn't be precluded from the options available so long as your medical history allows it.
Thank you. Now, there's a question about the pump and where exactly that goes.
Okay. So got a model here. I don't know if you guys can see this. This is the actual reservoir. This is filled with water right now. Traditionally speaking, most people used to put this in what's called the inguinal canal. If you hear about people getting sports hernias, there's something called a canal there that people will put that into. I've been putting them underneath the middle of the muscles, actually, right at the bottom of your abdominal muscles. I'll create a little pouch in that area, so it sits right underneath your abdominal muscles near the bottom.
I think that's the pump.
Oh, the pump. I'm sorry. I thought you meant the pump. This is the pump here. That goes in the scrotum. So we try to put it in the scrotum in a place where it's kind of shallow so you can feel it easily. Because once it's in the body, you kind of have to imagine where the pump portion is and where the release valve is. I don't know if you can see that there. But we put it into the scrotum so that you have access to it.
And the question said an internal or external component. So just to clarify, everything is placed inside.
Yes, everything is internal. Nothing's going to be exposed on the outside.
Question: if you've already had or are already on testosterone replacement injections, would you still qualify for surgery?
Yeah. If the testosterone, and this is what I was talking about before, testosterone doesn't just fix everything. If you're on testosterone, you're still not getting erections. Yeah. Once you've tried a couple other therapies and you failed, yes, you can still have, you can still do that. And it may be that one of these things where the testosterone is treating other things like mood or fatigue, loss of bone loss or muscle mass and things like that. But that's not a reason you couldn't get the implant.
There's a question about orgasm and the ability to ejaculate. So if somebody gets an implant, are they still able to orgasm and ejaculate?
Yeah, so there is a chance when you do the procedure that the sensation nerves can get affected. So if that happens and things go numb, obviously you're not gonna probably have an orgasm. You're not gonna feel anything. But barring that, what controls ejaculation and orgasm, they're completely different nerve system. It's not in that area, so those should not get affected.
Looks like there's no further questions at this time. So I'll put a last call out for questions. And while we do that, Dr. Park, what's the best way to get a hold of you?
Call our main office, and if you're interested in an implant, you don't even have to mention my name. You'll get sent to, we do have a men's health clinic that's starting up. You might get sent there depending on timing. You might get sent directly to me. If you're already seeing one of my partners, there's a couple doing implants, but I think I'm by far doing the most at this point. If you just say I'm interested in an implant, you'll find your way towards me most likely. So
just so people know, we will send out, there's another question here, an email tomorrow with contact information and that website.
Sure.
How do you determine the size of the implant?
That's a good question. So the body of the penis is much bigger than you think. What you see on the outside is not the entire length of that chamber. So once we open up that chamber, we actually use these, they're called dilators. They're like rods that have measurements on them. We actually measure the entire length of that body, that cavernosal body, and we try to get you the size that fits adequately. We don't want to go too small. We don't want to go too big. If you go too big, you run the risk of what's called erosion, where that material can dig into other tissues. But we try to get you the correct size based on what those measurements are.
Thank you. And I don't see any other questions at this time. So again, we will send out the website information and contact details for Dr. Park,
Sure.
Urology Specialist, tomorrow. We'll still wait for any of the final questions coming in, but while we're doing that, Dr. Park, I really want to thank you for your time, all the information that you shared tonight.
Yeah,
and I also want
to
thank you.
I really appreciate it.
Everybody who showed up for this evening's webinar. So Dr. Park, do you have final words of wisdom or anything you want to say as we?
No, just know that there are options available. This is one of these things where some people just, even in the healthcare profession, they just don't know a lot about it because they don't deal with these things. So If you're having issues with sexual function, don't be embarrassed to come talk to us. We have lots of availability of options for you. Not necessarily just implants. You know, if you're not interested in an implant, you want to try the other options, feel free to come talk to us. We'll help you guys out.
One more question here. Oh, what advice do you have for patients to help them prepare for this type of surgery?
The more you can keep yourself in shape before surgery, like if you can lose some weight, that always helps. If you're a smoker, you know, it's best to quit. But even if you're a smoker, if you can just quit temporarily, that will make a difference as far as wound healing and infections. If you're diabetic, just make sure that you really keep your diabetes under control, especially around the time of the surgery, because that will help lower your risk of infection.
So really great questions and great responses. So Dr. Park, I want to thank you again, and then thank everyone for attending and engaging in tonight's Men's Health webinar. This concludes this evening's presentation. Good night, everyone.
All right, good night.